because I cannot hear you. Thank you very much for the opportunity. I am so sorry, everyone, to all the students that are listening. I know how frustrating it is when the technology doesn't work, and it must be from my side. I have tried to test them, but I'm going to talk about osteoporosis, and this is an important area. It is a metabolic bone disease which is characterised by low bone mass, but also microarchitectural deterioration of the bone. So the important aspects are that the bone fragility leads to increased fracture risk. Osteoporosis is a disorder in which the loss of the bone strength leads to that fragility fracture. And the fundamental pathogenetic mechanisms underlying the unit, and that can lead to bone loss. And prior to menopause, there may be replacement of that, and the rate of remodeling, resorption, formation can lead, as you can see in this graphic, that the bone slowly has less bone in it, and there's a slowing in the rate of bone formation, and then we can see that this is determined by the activity and lifespan, the osteoclast and the osteoblast cells. So we've got that loss of trabecular bone in women, which occurs by increased resorption with loss of trabecular numbers and connectivity, which you can see there, the bone is thinning due to reduced bone formation that occurs in men as well. So we've got these sort of differences that are occurring in men and women due to changes in resorption and decreased formation, and in men more decreased in formation and lesser effect on resorption. So during aging, the absolute amount of that endothelial bone loss is similar in men and women, whereas the absolute amount of the periosteal bone gained is less in women than in men. So the net lost from the whole bone is greater in women than in men because of the hormonal differences in the absolute bone gain, not in the bone loss. So I think this is an important concept to understand in the differences between men and women as they age. And you can see that pictorially here. And this has implications for our drug treatment. So in osteoporosis, the structure of the L vertebrae in a 30-year-old woman, and you can see the bone architecture, and there's more bone in the bone, whereas in a 70-year-old woman, you can see the change in the structure at the L3 vertebrae, where there's this loss of bone and the bone architecture is impacted. So peak bone mass, as I said earlier, is very important to understand, because how much you attain in adolescence and in childhood, that peak bone mass is very important. If you don't attain a good peak bone mass, then that age-related bone loss is exacerbated, because if you are lower on that curve, then as you age, then you can see that your bone mass will decline to quite low levels if you don't attain a good peak bone mass. And certainly in Australia, in our situation here with calcium intake, we find that some of our young children and our young adolescents are not consuming as much dairy products as previously. and they're also not undertaking the exercises that they need to do to attain that peak bone mass. So it's not only to do with the amount of calcium that is consumed in childhood and adolescence, but it is also related to the type of activity. So we have more sedentary lifestyle, so not as much exercise and not as much exercise that is like skipping or jumping, so that it lays down and increases that peak bone mass. So achieving peak bone density and quality requires adequate nutrition and weight-bearing exercises, usually in late teens and early 20s, and adequate calcium and vitamin D. So children that don't get outside very often don't get enough calcium and vitamin D, and they don't undertake enough weight-bearing exercise to gain that bone mass, because you need that weight-bearing exercise. Be skipping, weightlifting, not just walking. Static loads applied constantly, such as when standing, do not just promote increased bone mass. The influence on the bone mineral density is greatest in early puberty and during adulthood, which serves to conserve the bone mineral density and reduce the rate of bone loss. So we'll look at the WHO definitions. These are defined as osteopenia. And osteopenia is where you have a T-score -1 and -2.5. So these are the standard deviations from normal in the population. So between 1 and 2.5 standard deviations from normal for that age would be considered osteopenia. Osteoporosis is defined by the WHO as the bone mineral density at any major skeletal site, which is 2.5 standard deviations or more below the mean for a young healthy adult. But severe or established osteoporosis is now a combination of two things, and that is that the T-score needs to be less than 2.5 standard deviations from normal, and the person has fragility fractures. And those fragility fractures can be in the vertebrae, they could be in other, like in the wrist, or where the person has sustained a fragility fracture from really low impact. So these three things are important, and the established osteoporosis is a strange kind of phrase, but severe osteoporosis, you need those two things, the -2.5 and the fragility fractures. So we use the T-score and the Z-score. The T-score is for diagnosis. That correlates well with fracture risk. Then we have the Z-score, which is used to assess the whether there's a secondary cause for that person's osteoporosis, and that there may be another reason for that person to have developed osteoporosis. When we look at the risk of fracture, it increases exponentially with a decreasing bone mineral density. So between 1.5 to 2.5-fold increase risk of fracture for every standard deviation that person is from normal in terms of the BMD. And the normal is age adjusted. So when we look at the age adjusted increase in relative specific fractures, this information has now been really well confirmed that increasing someone's if someone has increasing standard deviations from normal with their osteoporosis, and they are likely to sustain a fracture and increase fracture risk. This shows you a little bit more clearly across other countries and also by age. And I use this to show that really what you can see is that at that age 70 for both men, for women at age 70, you can see that inflection point where after the age of 70 that their risk for hip fracture increases exponentially. For men, that occurs about a decade later at age 80. Now, the different countries. Australia is represented by the square box filled in, and whereas you can see that for Hong Kong there, that for women it maybe is delayed a little bit to 75 years of age, where that next inflection point is for increased risk of fracture. So age contributes to risk independently of the bone mineral density. So in Australia, as we plan for an ageing population, and I know in India as well, you also have an ageing population, osteoporosis becomes a very important, serious public health concern, and osteoporosis-associated fractures cause a great burden not only for the individual patients, their families and carers, but also at a broader society level. So it is becoming a very important issue as we have an ageing population, both here and in India. The lifetime risk for osteoporotic fractures at the wrist, hip or spine is about 30 to 40%, and mortality rates within 1 year of a fractured neck or femur is typically reported as between 20 and 35%. So if you're an older person and you sustain a hip fracture or a fractured neck or femur, then your mortality rate within 1 year is very high. And one of the concerns is that it's not only the mortality rate that's very high, but also the morbidity, because a fractured neck or femur can lead to loss of function and then deconditioning, and then that affects mobility and that person to lead an independent life. 15% of patients who live in the community before sustaining a hip fracture in our Australian context then require nursing home accommodation because of the morbidity that I refer to. That they then longer can care for themselves independently. So osteoporosis is not just about the low bone mineral density. As I've said earlier, we have to think about the peak bone mass, and I think this is important to understand that. Lessons to achieve their peak bone mass, and this has become increasingly important in our country. As I said, children are not undertaking the same physical activity that they previously were, and it may impact if they consume less dairy and less calcium and don't get enough sunshine, and therefore have lower rates of vitamin D. Surprisingly, in Australia, with all of the sunshine that we have, we still have quite high rates of vitamin D deficiency, because people are not going outside in the sunshine as they used to and not getting that vitamin D. And that affects, and then we've got bone remodeling and then also clinical risk factors. Then there's the bone density, but also the bone quality. I showed you some pictures earlier on that it's not just the that a person has in their bones, but it's also the microarchitecture, the bone matrix. These two things together, density and bone quality, they contribute to bone strength. And maybe their bone quality is not be. It's then these other factors like falls which really contribute to that fracture risk. So BMD only one component of fracture risk. Accurate assessment of fracture risk should take into account other readily measured indices of fracture risk that can help us understand a person's risk for a fracture, and particularly a hip fracture. In Australia, 1 in 10 Australians aged over 50 have osteoporosis or osteopenia on self-reported data. So, as I said, with an ageing population in India and in Australia, this is a very prevalent and a problem for us. So minimal trauma hip fractures is one of the most serious and debilitating outcomes of osteoporosis. The treatment of this fracture invariably requires hospitalisation and may require surgery. If someone fractures their hip, they will usually have that either pinned or require a replacement, which might lead to ongoing pain and disability. We had over, I know these are not very large numbers by your standards, but for us, these represent quite a high rate of hospitalisations from minimal trauma hip fractures. And if I could have more interaction, I would check, but I know that the sound is not very good, so I'm apologising for that in advance. But I had a look at some of the rates of hip fracture in your country, and also have quite a high rate of this in older people. It is more common in women in our country than it in men, and as I showed you earlier, that for women occurs at a younger age, from 70s onwards, whereas for the older people aged 85 and older, and there's very, very high rate of hospitalisation. We had been looking at hospitalisations following minimal trauma by fracture site, and this may be something that you can see in your own hospital settings where you are working as students and as faculty, looking at the rates of hospitalisation following a hip fracture, both in the acute and subacute setting. And it only has been rising in Australia, and it would be interesting, students, to look at what the hip fracture rates are in your country as well. Then differences between men and women, and again you can see that in older women there are much higher rates of hospitalisations with hip fractures than there are for men. And I showed you at the beginning that the presentation there are those differences between resorption for men, and so the bone strength is a little different between the two. This is just to show you some work from a study that was done in Scandinavia. And this just shows you that it's not only about bone mineral density, that people still can sustain a hip fracture even when their bone mineral density is okay, so their BMD is not considered to be osteoporosis. And this reminds us that in these countries where there's a lot of ice and snow and where people can fall and slip, that you can still fracture your hip, even with good density. So we still have to be alert to falls risk and to ensure that we not just treat people with medicine to increase their bone mineral density, but pay attention to those other risk factors that might lead to a fall. So we do need to remain vigilant to the increasing burden of osteoporosis and focus osteoporosis, but also to reduce fracture risk by recognising some of those factors that contribute to that, such as falls assessment and the medicines that older people may be taking that contribute to falls, because that would be a preventable way of reducing falls and the burden of a hip fracture. And I wanted to emphasise that before we moved on to the anti-osteoporotic medicines, because it's not just about treating BMD. This is just some of the key milestones in the course of osteoporosis therapy. And certainly, hormone replacement therapy was very commonly used to treat osteoporosis and to reduce the risk of future fractures. But this was studied more, and a very landmark study called the Women's Health Study showed that the benefit of hormone replacement therapy in reducing fractures didn't outweigh the risk of breast cancer and the thromboembolic risk associated with replacement therapy. And so it's a reminder to us that when we might be trying to treat one problem, we do need those randomized controlled trials to really show us the efficacy outweighs the harms. So hormone replacement therapy is not widely used anymore for prevention of osteoporosis unless there are other reasons for that hormone replacement therapy, such as symptoms, menopausal symptoms that the woman would be taking that for. Then in the 1990s, we had the oral bisphosphonates, and we still use those reasonably commonly, but much less commonly now, and I will come back to that. So these are residronate, and again, interesting to us as pharmacists that when they were first introduced, they were given daily, then monthly. So recognising the long half-life of these drugs, that they could be given at much longer dosing intervals than as frequently as they were given when they were first introduced onto the market. A drug like teriparatide is not widely used, and it would be a third or fourth line agent because of the risk of severe side effects that may occur, such as bone cancer. And then strontium came, and we don't use that anymore because of the side effects that were associated with that drug. And then IV bisphosphonates, so zoledronic acid. And then 10 years ago, Denosumab came onto the Australian market and is now most commonly used anti-resorptive or anti-osteoporotic agent. So again, just to look at this in terms of where these drugs are working on bone resorption, and we've got the bisphosphonates and denosumab, the most common agents we use there. And you can see that also they prevent loss of the cancellous bone and prevent that cortical thinning. The rankle receptors are located throughout the body where the denosumab is working to look at that and influence both osteoclast and osteoblast activity. As you can see here, just looking at the yellow stars show you where the denosumab is working, impact osteoclast and osteoblast activity. The selective estrogen receptor modulators, or SERMs, again, you can see where they are working there on that graphic. Newer agents, which we're not widely using yet, depicted here on this graphic. So in Australia, this just gives you a timeline of when these medicines were listed for public subsidy. And as I said, the introduction of Denosumab in 2010 has very much changed how we treat osteoporosis. And with that comes need for pharmacovigilance as we become familiar with different adverse effects associated with denosumab from the bisphosphonates. So, again, we can see that the average starting age of osteoporosis medicine in Australia is 71 years, and approximately half of the people starting in osteoporosis therapy were prescribed denosumab. I'll show you some other data to show that in 5 years from the time it was introduced, approximately half of the people were starting, and then the next 5 years from 2015 to 2020, it's almost all people starting on that drug. So denosumab is available, and it has an approved indication for the treatment of osteoporosis in postmenopausal women. And the treatment to increase bone mass in men with osteopenia that are receiving androgen deprivation therapies for non-metastatic prostate cancer, and the treatment to increase bone mass in men who have osteoporosis and who are at increased risk of fracture. It's also approved for use in osteoporosis in postmenopausal women, and it is widely used. So we can see here the other agents. We'd use combination of residuinate with vitamin D and calcium, and that's used for those people who have osteoporosis, but also is approved for those people who have glucocorticoid-induced osteoporosis, and to preserve bone mineral density in those people who are undergoing long-term corticosteroid therapy. So I just wanted to highlight again the route and frequency of administration, and this can be important for adherence to medicines, and certainly with denosumab, it's given as a subcutaneous every 6 months. So this means that, again, in the Australian context, that people would come to see their doctor and to have administered every 6 months. For people, older people in care homes, then that can be administered by the doctor or by a nurse who is trained to administer that. Person that's on the residuinate or alendronate combinations, then that is usually taken monthly for residuinate, and that means that we as pharmacists have to those people to take that medicine well, being aware of the risk of the esophageal ulceration associated with these, with the bisphosphonates, and again for older people to make sure that they know how to take it and are reminded to take it. They are relatively forgiving medicines, the bisphosphonates, because they have a very long half-life. So if a person did forget to take their medicine, then it wouldn't be too big a problem, and we would just have a process by which they might have a calendar. They take it on this each week or the same day each month to remind them when to take those medicines. And this was just to show where, types of medication. So the bisphosphonates slow bone loss by reducing bone resorption. They bind very strongly to bone mineral, and they form a depot from which they are released as the bisphosphonate-containing bone is decreases bone resorption and increases bone mass and strength. So again, because denosumab is increasingly being used. We can see here how the denosumab is working, and it is effective, like the bisphosphonates are also very effective. And I will be interested to learn from you what are your most common drugs to treat osteoporosis. But certainly the denosumab and other monoclonal antibodies are becoming more widely used for the treatment of osteoporosis. But we do, as I said, need to be then aware of pharmacovigilance, and we use these medicines effects significantly more frequently in the denosumab group than placebo showed cellulitis, eczema. But eczema, I think, is a really important one, particularly for older people who have dry skin. And if it's a drug that's been given every 6 months, and it's important as pharmacists, and again, we're reviewing patients in the hospital situation, to be aware that a medicine that might have been given 6 months ago may then cause something like eczema. So we need to be using our kind of clinical thinking, our clinical reasoning to look for some of these side effects in medicines related to medicine that might not be temporarily administered. And so people don't think, oh, that eczema or that cellulitis is related to the drug that was given by injection 6 months ago. So serious skin infections may occur but are uncommon, but we need to be alert to them. And we need to perhaps, again, have studies that look at the use in immune compromised patients or those patients that might be on immune suppressive therapy. The other thing with denosumab is the serious infection that might occur in the abdomen or the urinary tract. And although as we use other drugs, so for diabetes, for example, we might be using a drug like Closen, which this might increase urinary tract infections. And so again, being alert to maybe more than one drug that might be contributing to that worsening. And so that multi-morbidity and pharmacy requires us as pharmacists to be really looking at those medicines. While the individual risk might be small, they might be rare, but as we use these medicines more commonly, these are areas that we need to be vigilant to. And bisphosphonates and also with denosumab is that over the last 10 to 20 years of use, we've become aware that these powerful medicines, both denosumab and the bisphosphonates, they can cause atypical femoral fractures. And that is doesn't occur in everybody, but the risk of atypical femoral fractures for these powerful anti-resorptive medicines. So advice for healthcare professionals is that we need to remember that patients should be advised to report any new or unusual hip or thigh or groin pain. And atypical femoral fractures may occur with little or no trauma. So remembering that we're giving these medicines to people who might have osteoporosis, and who might sustain minimal trauma fractures. So again, it's being aware that if the powerful anti-resorptive can atypical fractures. I just wanted to show you in Australia how quickly the use of denosumab changed from the alendronate and the bisphosphonates alendronate and the risedronate. So again, we'd be thinking about the differences in the side effect profile that we might be seeing. The other vitamin D is important and again, it's important as supplementation, not big doses of calcium or vitamin D, but really to replace what would be normally consumed. And so some people who have osteoporosis might not be consuming dairy or getting enough calcium in their diet. So it's really replacing that calcium back to a calcium supplementation, not over supplementation. Because some of you might be aware, professors and those in faculty who are teaching you might have read that if we have too much, there have been some studies looking at cardiovascular risk associated with too much. So it's really about replacing appropriate calcium and getting the right amount of vitamin D as well through, again, a balance between sun exposure. The other thing for us, I suppose, pharmacists, is thinking about the drugs that might affect osteoporosis and also fracture. So medicines for whom there appears to be significant risk for osteoporosis and fractures are the corticosteroids, but also thyroid hormone excess, some of the anticonvulsants, particularly phenytoin, heparin if it's given as chronic therapy, depot-medroxyprogesterone. Some cancer therapies can induce hypogonadism, the thiazolidinediones, which were used for, and some antipsychotics. Medicine which might possibly increase osteoporosis and fractures, again, commonly used ones there are loop diuretics, so furosemide, opioids, proton pump inhibitors, warfarin, cause significant osteoporosis risk, and approximately 30 to 50% of patients who receive long-term high-dose oral corticosteroids will experience a bone fracture. So again, we need to be very vigilant to the dose that people are on corticosteroids. Increase up to 6 times the prevalence of vertebral fractures and doubles the risk of hip fractures. Major impact of corticosteroids occurs within the first 6 months, but continues to a lesser extent for the duration of therapy. So really, in that first 6 to 12 months, there's an initial rapid loss of up to 30% of BMD. And therefore, this is a really important thing that we need to know of when people are starting on corticosteroids, making sure that they've got enough calcium and vitamin D. It sometimes is important in those men that are taking higher doses and for longer term to measure their testosterone levels and commence specific therapy in those specific anti-resorptive therapy when long term. I also was going to just quickly mention the opioid because these are increasing in use and they may cause increased fracture risk. And this is some pharmacoepidemiological work that shows up on the top panel, you can see composite fractures is very much increased when people are taking opioids. And again, may not be as common in India, use of opioids, but we've certainly in Australia, North America, the United Kingdom have seen a big increase in the use of opioids, and particularly in older people. This is just to show you that here you can see by collecting the data, looking at the defined daily 1,000 of a population, increase in those people over 7 years. And this matches the very people who are most at risk for hip fracture. The recommendations that is the top of the list is to review medicine, especially high-risk medicines such as sedatives, antidepressants, antipsychotics, and centrally acting pain relief to reduce the risk for fracture. So it's not just about giving anti-resorptive medicines, not just about giving and making sure they have calcium and vitamin D, but looking at what medicines might increase the risk. Fracture risk calculators, and you may have similar ones in that are suitable for use in India that reflect your population, but calculator, just a guide to work out. But again, as a pharmacist, we are looking at not only the treatment with an anti-resorptive medicine, but also looking at of the other medicines be contributing to that risk, and then the risk of osteoporosis and affecting bone mineral strength and density, but then also the medicines that might be contributing to dizziness, to increased risk of falls that may compound the problem and lead to a fracture. So these are the important areas for us to be thinking about with an ageing population, increasing risk associated with osteoporosis, and then increasing polypharmacy in older people that might contribute to increased falls and then increased fractures. So I will stop sharing my slide. Pons, I'm not sure if you have any questions. I know I've got about 10 minutes more. I have talked a bit quicker because of the slow start, which I apologise again very sincerely to everybody.
That is okay, Dr. Deborah. Now the session is to participants. If you have any questions, you can ask. Dr. Deborah, can you put your video mode on? Yes, madam. Deepa madam wants to ask some question.
Sir, Ms. Deborah,
and if you would like to use the chat function, Pons, that would be very good. I could see the questions.
Yeah, madam, you can use the chat option to type your question here. Yes,
okay,
please.
Sir.
Yeah, please.
Deepa, for some reason I cannot hear when you speak. So, Deepa, if you could chat, that would be lovely.
Yes, yes. Deepa madam, can you please type your question here?